therapists. Today, I'm excited to welcome Dr. Bill Miller and Dr. Ricardo Muñoz, who are going to be discussing their new book, Rethinking Drinking. Welcome.
Thank you for having us.
Thank you.
Your first book came out in 1976 together, called How to Control Your Drinking. What would you say has changed the most in the science since that first book?
One of the things that's changed, I think, is just consensus on the safety of alcohol use. The World Health Organization now says there is no truly safe level of alcohol consumption. That whatever level of drinking you do, there's some health risk attached to it. That's certainly different from the messages when we were writing it first in the 1970s. So the science has changed, and we just know a whole lot more about alcohol use disorders and drinking in general. And American drinking practices have been changing as well. About half of American adults now don't drink at all or just occasionally have a drink. That's so different from when we began. Drinking's been going down steadily since about 1980.
One other thing that has happened is there's a lot more evidence that self-help books like this one can actually have impact on a lot of psychological conditions, not only drinking, but also depression, anxiety, other kinds of things. So we really like to contribute to that, right? By making the things we've learned as clinical psychologists available to as many people as we can.
I think that is a really interesting concept that you bring up, and we'll talk more about just the science behind the drinking. But what are studies showing about using this self-help book or self-help books in general compared to using the book with a therapist?
Well, it was a surprise to us. I think the first study that I did like this was around 1975, and we were using our book as a control condition. So we were offering treatment to people who wanted to cut down their drinking, were concerned about their drinking. And as a comparison condition, we randomly assigned some people to just go home and work on their own using the self-help book. And the question was, on average, how much better will people do working with a counselor? And the surprise was there was no difference in outcomes between the two groups. Both of them decreased their drinking about 64%, which is substantial, certainly enough to have a health impact. I then came to the University of New Mexico and replicated that 3 times, that people are able to use this material on their own to, on average, have about the same outcome as they would if they're working with a counselor using the same methods.
It's such great research for accessibility to know that somebody could access the information and have such success with the book.
And of course, it can be used in conjunction with professional help too, right? So it can be a tool that a professional counselor could also use. One of the things that's important to note, I think, is that Bill's dissertation, which was the first study that actually tested the book, was really in a very controversial topic back in the 1970s, because back then people thought that there were only 2 kinds of drinkers, right? People who were alcoholics and who couldn't drink at all, and then everybody else who could drink without worrying. And I think Bill was one of the first people who began testing whether you could help people who were having problem drinking to learn to drink moderately. Maybe you could say more about that, Bill.
Well, it's become routine now. I mean, when you go for your checkup, probably your doctor asks you not just about smoking, but also about your use of alcohol. And that's changed in the last 10 years or so. And also the doctor may provide you with some materials to help you cut down on your drinking. And there's some medications that doctors can prescribe now to help people cut down on the drinking as well. So it's become routine in healthcare just to ask about alcohol use as a health risk factor, and to suggest that people cut their drinking down or stop, depending on their situation. But yes, when we started this, it was highly controversial because either you were alcoholic and would be unable to cut down your drinking, or you weren't, and what's the problem? You can drink whatever you want. We now know that the latter is not true.
There was a funny line in the book that said, so basically this was for no one.
Right. Nobody did our book.
Yeah.
Because either they couldn't do it or they didn't need to.
Yeah.
But people used it anyhow. So,
So our focus back then was to help people to learn how to do moderate drinking.
yes.
That was the focus. And I think, again, this is the fifth version, basically, of our book, 50 years later. And now, with the knowledge that there are so many health risks that we were not as aware of back then, one of the choices, of course, is not drinking at all. But we totally respect and acknowledge people's right to make a decision. You know, we all take risks with things. Every time we get in a car, we take a risk, right? That something could happen. So we very much respect people's right to make choices, but they should make choices knowing the most accurate information currently available. So that's the point of the current book, Rethinking Drinking.
Yes. Ricardo made a choice long ago to not use alcohol. And I do drink, but very moderately, less than a glass of wine a day. And so we represent two choices that one can make. And the book really is all about making those choices for yourself, and nobody else can make that choice for you.
And ideally making those choices not in an emotional way, but just thinking, again, rethinking your drinking and decide whether you want to use alcohol, and if so, how to use it in a way that's least likely to create problems for yourself and other people. I mean, that's really the point. You know, Bill mentioned that I decided not to drink, not out of religious or other reasons, but just it seemed like a logical choice back when I was in college. Back then in the 1970s, I was at Stanford, and in the dorms, people would pass joints around, marijuana joints around, and every time we got together, and I would just pass them on to the next person. And one time, this guy who had just given me a joint said, "Yeah, so you don't smoke?" And I said, "No." And he said, "Well, do you drink?" And I said, "Yes." And he said, "Well, drinking is a lot more dangerous than marijuana. And if you don't believe me, look it up." So I went to the library and I actually looked it up, and I found all these problems with alcohol. I mean, problems with your brain, affecting your emotions, and all these problems like violence and sexual abuse that occurred when one or both people were drinking. And of course, all the alcohol, related, auto accidents and other accidents. So there were all these problems with alcohol, and I thought the logical thing was not to drink and not to use marijuana. So I did nothing. At first I had to explain to people why I wasn't drinking. Back in the 70s, you were expected to drink when you were in a social situation, and people would actually get upset with you if you didn't, which was really something. And after a while, I got used not to even, mentioning it. I just don't do it. And it has had an impact like on my family. My immediate family doesn't use alcohol, that's just not part of what we do. But it's not any big deal. It's not like not big emotional thing. I'm not asking people not to drink. If people want to drink, I think that's their choice. Hopefully, not drinking in a harmful way, which again is the main focus of the book. How to drink in a way that was not going to have harmful effects on you or your family or people around you.
Yeah, especially like you mentioned that almost half of people report now that they don't drink. It's a good time not to, because there doesn't feel like there's as much social pressure as maybe there was when people were expected to earlier on.
You have lots of company, and now it's normal in restaurants to have alcohol-free beverages offered. You go in a grocery store, there are shelves of alcohol-free wines and beers and things. So it really has changed quite a lot.
My brother works in the rock industry, heavy metal, those kinds of things. And he was telling me that people now have these cans of water that have names like liquid death and all these kinds of things. And people are using these instead of alcohol because they want to have something in their hand that looks like it could be alcohol, even though it's just plain water. It's interesting how things have changed in the last.
Yeah.
Yeah.
I just saw this week that Coca-Cola did a rebrand to have a more evening looking black and gold can. So everyone's following suit. In addition to some of those social pressures, what were the other reasons for drinking that people have identified in your research?
We talk about reasons that people drink because we're looking at the pros and cons. And I think the most common one probably is I like the taste. I just enjoy a glass of wine now and then. Or socializing is a pretty common one too. When I'm with friends, out with friends, I like to have a drink. That it just maybe helps me relax a little bit, but mostly it's just part of socializing for me. Then you get into I like what alcohol does to me, and it helps me relax is an example of that. And there you're talking about partly a chemical effect of drinking and partly a psychological effect, because we've known for a long time that if people believe they're drinking alcohol, their behavior changes in the same kinds of ways that it does when people are drinking alcohol. One of the things we say in the book is that if you think you've had a drink, this has been done experimentally, you give people something that they think has alcohol in it, they kind of relax and they start having a good time, and their mood just kind of lifts for a while. And Ricardo knows a lot about mood research. And then if you are drinking, then the alcohol begins to kick in, and the actual effect of alcohol is depressant, and so literally you may get a happy hour, and after that, it's pretty much downhill from there on from the chemical effects of alcohol. But people look for those effects. I feel stronger. I feel more courageous. I feel less anxious. So if you're using alcohol to change the way you feel, now you're getting into more risky use of alcohol. And people who report those reasons for drinking tend to drink more, and tend to get in trouble more. And at the top end of the spectrum is drinking in order to drive away the effects of withdrawal. So you become addicted to alcohol, which you literally can. And when you drink alcohol, then that discomfort goes away, just like other drug addictions. And of course, that one is the most associated with alcohol problems and the most drinking. So why you drink matters. And that's one of the things that we look at in this book.
Yeah. So the first parts of the book, focus on those things. Drinking, reasons for drinking, reasons for not drinking, and the effect of alcohol on your body. I mean, BAC levels and so on. Then we get into a great detail. Alcohol is a drug, right? It's a drug, and it's important to know how the drug works on your body in order to make a rational decision as to how much to use. So that's the first part of the book. The first 3 parts of the book focus on all these things. And then part 4 of the book focuses on alternative ways of achieving some of the things that alcohol does for a lot of people, like Bill was mentioning, dealing with low mood or anxiety or getting to sleep, and so on. And unfortunately, even though it does help some, it actually has a number of negative consequences for all of these: anxiety, depression, sleep. And so we talk about those things in part 4 of the book, and we provide alternative ways of achieving those goals.
I heard even this week, the first drink is the most fun. And then I spend the rest of the night trying to capture how good that first drink felt, and it never comes back.
Literally true. That's the happy hour. Yeah.
Yeah. I love that.
Well, we really have a couple of audiences for this book. Originally, we wrote it for people who kind of know they're drinking too much, who are drinking, above what would be regarded to be reasonable limits. And we were trying to work with them just to get their alcohol down. My first experience with alcoholism was actually in an inpatient treatment ward at the Veterans Hospital, seeing people whose lives had basically been destroyed by alcohol. And what that convinced me was I wanted to go upstream and try to keep people from falling into the stream before they got down to those waterfalls that I had seen. And so we were trying to work with those folks who were already drinking too much to cut it down. Now the book is also for people who are saying, do I want to drink at all? I mean, why am I drinking, and how can I decide? And so we look at the pros and cons for people that don't have a problem necessarily with alcohol, but are just thinking about, this is a drug and I want to make a good decision about how I'm going to use it.
Mm-hmm.
And we mentioned, the impact that alcohol has. 178,000 deaths due to alcohol a year in the U.S. Like that's 480 some a day. I mean, I think many of us are not aware of how much impact alcohol has, a negative impact on our lives. And then there are, again, other ways. Bill's point about trying to prevent people from getting into the severe alcohol problems that he was working with in the inpatient units. That was the main goal of our first version of the book. Mm-hmm. But now we're talking about ways of preventing not just alcohol problems, but things like depression, anxiety, and things like that. We talk about those things in the book and in part 4 of the book. So we're both very interested in prevention.
Yeah, I think that piece is interesting too, because some people would identify that they are, to your point, drinking more so they can sleep better, or because they've been having a hard time or feeling a little bit depressed. But you're noting that those things actually increase and get worse with alcohol use. They don't actually improve, especially in the long term.
Also built into the book this time, sort of a self-checkup for people who wonder, I wonder if I'm drinking too much. And that was a group that in my own research, I was interested in helping too. And we offered free checkups in the newspaper for people who just wonder whether they're drinking too much. You won't be labeled. It's not a treatment program. Just come on in. We'll do some measurement with you, some assessment. We'll give you feedback, and that's it. We called it the Drinker's Checkup. People came to that who had never been near a treatment center, and yet almost everybody who came in wondering whether they were drinking too much was. They were drinking at a level that was doing some harm to them. So part of them knew already, but they didn't want the label of I have a problem or I'm an alcoholic, whatever. They just wanted to make a decision about their drinking and how alcohol is affecting them. And so the book is really for folks like that too.
Yeah. Could you give an example of the type of question that would be found on the checkup?
Sure. I mean, we certainly ask questions about the amount that the person's drinking, because that's directly related to the amount of harm. And most people haven't thought about it. In the treatment programs that I ran, we had people actually keep little cards. And every time they had a drink, before they had a drink, they would write down the time and the day and what they were having. And people found with that, actually, they were surprised. I never really thought about how much I was drinking. And at the first week, we said, you don't have to make any changes in your drinking, just write it down. But in that first week, drinking went down by about a third. And people said, I went to write it down and I thought, do I really need this one? So just that awareness of how much is a piece of it. We have questions about the kinds of life problems that people can run into and whether those are happening. And you can compare yourself with the scores of other people. We actually did, and we can't do this in the book, but we did some neuropsych testing of brain functions that are very sensitive to alcohol and that get changed early. And you may not notice them even. But so we tested those things to look for early effects of drinking, and we give people feedback about that. We took a blood sample and we looked at liver function. And most of the people coming in to our programs or for the checkup weren't in trouble at that level. Some of them had elevated liver functions, but Most of them haven't done that much damage yet, which is perfect because we're looking for prevention, So just a variety of things like that we've built into the checkup. Trouble that you can have with it, dependence is also, to what extent is alcohol beginning to be built into your life as something that you're just used to, and in fact, a little uncomfortable without it, And so you can get yourself a score on the extent to which that's happening. So we just look at a whole variety of things in the checkup, most of which we could do in book form. We couldn't do the neuropsych testing or the blood testing, of course. But otherwise, we could build into the book the kinds of things that we were looking at.
One of the things we talked about at the beginning of part 4, chapter 12, is this idea of the healthy management of reality, by which we mean that most of us learn from the time we're infants how to deal with our world, right? I mean, we learn the language that our parents speak, we learn how to behave, etc., right? And sometimes the things that we use to manage our day-to-day lives are very helpful. Most of the time they are. But from time to time, we learn something that may not be very helpful. For example, a lot of drinking begins in adolescence, when young people are trying to figure out how to become sociable, how to deal with emotions, all those things. And so they begin to learn to manage their emotions and their social interactions with alcohol, because alcohol is so available, even though it's illegal, to drink underage, but still it's so available. People are beginning really early. And so once you've learned to use alcohol for these things, it's very hard to give it up and learn an alternative way of doing it. One of the things we talk about is the idea of freedom. If you have 3 choices to do something and somebody else has 10 choices, the person who has 10 choices has more freedom, right? If somebody only knows how to deal with depression by using alcohol, they really don't have any choice. But if they can learn other ways of doing it, then they have choices. They have freedom. And that's what we're trying to encourage. It's increasing people's freedom. That's the point of the book.
Yes. Mm-hmm.
Yeah, that's a neat way of saying that. I thought this was an interesting fact that you shared, Ricardo. Your senior thesis advisor was Albert Bandura.
Yes.
And so you mentioned that in chapter 12, some of those ideas are based on his self-efficacy research.
Exactly. Yes. I mean, one of the problems, with depression, for example, is a feeling of helplessness and hopelessness, right? And the feeling that you cannot deal with whatever is going on in your life. And sometimes people use alcohol to deal with that, right? I mean, you hear this all the time. I need a drink at the end of the day because of all the stress you're dealing with, right? And so I did my senior thesis with Albert Bandura in Palo Alto, working with adults in Palo Alto. And then I did my dissertation with Peter Lewinson at Oregon, again, working with adults there. And both in Palo Alto and Oregon, the people I was working with were almost entirely white people with good education and good salaries and so on. And then I came to San Francisco General Hospital. I had grown up in the Mission District I immigrated from Peru when I was 10 to the Mission District in San Francisco. And I was very lucky to get a job as a professor at the medical school at UC San Francisco, based at San Francisco General Hospital, which works with very low-income people. And their day-to-day reality was totally different from people in Palo Alto or Eugene, Oregon, which is, it's a college town, basically. And so I had to change the way I was thinking about cognitive behavioral approaches. I was just telling people, think differently or increase your pleasant activities a day. It didn't seem like that was really sufficient. So I came up with this idea that you needed to shape or manage your day-to-day reality using cognitive behavioral methods. I mean, we would teach people about how their thoughts affected their mood, how what they did affected their mood. But the point was to shape or mold their day-to-day realities. That's the point. And so that's what part 4 of the book deals with, different ways of using your thoughts and your behaviors to change your day-to-day reality, whether that be depression, anxiety, sleeping, etc.
There's an advertising message in America also that you shouldn't have to feel uncomfortable And if you do, take something.
Yes.
When I was young, it was aspirin. Just take something to feel better. But now, of course, we have a whole panoply of drugs, and we have commercials for prescription drugs on television, which definitely was not true 20 years ago. And that ethos of the solution, if you're feeling uncomfortable, is to take something, is a real problem, because mostly what you take isn't particularly helpful. Sometimes it is, but mostly it isn't. And so part 4 of the book, again, is about things that you can actually do that don't involve taking something to have a better life, to enjoy your life, and to feel comfortable without taking something.
Yeah, I think about that cognitive distortion a lot in my practice, that it seems like pain is bad, or avoid pain can lead to a lot of these difficulties, but other ones too, if it feels like we're not supposed to feel difficulty or any pain is avoidable.
Yes, right.
That's a very good point. One of the things we talk about is that depression, like physical pain, is actually a good thing. I mean, we need to be able to feel depression or physical pain in order to protect our body or our emotional health. The problem is when depression, for example, becomes very intense, lasts a long time, or is very frequent. So that's what you want to do. You want to reduce the intensity, the frequency, and the duration of severe depression, just like you want to do the same thing with physical pain.
Also, Ricardo's research shows that depression is preventable using the same methods, particularly postpartum depression, women who have delivered. It's not uncommon to develop depression after delivering a baby. And that is preventable using the same kinds of things that Ricardo has been talking about that are used to treat depression when it does occur.
I think both of us were very much influenced by in the 1970s, by the focus on self-control approaches, right? That people had, there was a book called Power to the Person. I remember, Albert Bandura was one of the people who, the whole idea of self-efficacy is the idea of self-control that and we are very much focused on this idea that human beings have the potential to control their lives, their emotions, their behavior, and so on, in ways that, the radical behaviorists, for example, Skinner talked about, how we were totally determined by our past history and so on. And psychoanalysis also talked about how all these subconscious things affected us and we were not even aware of what they did. But Albert Bandura and other people who were doing work on cognitive behavioral therapy, focused on how the idea of reciprocal determinism, the idea that the environment obviously affected our behavior, but we could also affect the environment in order to change our behavior, right? I mean, that was a very freeing idea for me. I just love that idea. And then, I've been using that ever since then. And I think Bill and I both are focused on how to give people more of a sense of control over their lives.
Another piece of this that got some attention recently is how much better people feel when they let go of drinking too much. There was a book called Sober Curious a few years ago, written by a woman who said, I just wondered what life would be like for me without alcohol. And it sold well. I mean, it sold a lot of copies. And people were it was an idea that caught on. And the reason I've stayed 50 years in the addiction treatment field is the outcomes are so good. Most people get better, and most people get way better in a way that you don't need subtle instruments to measure it. So what a wonderful field to work in for me. I've really enjoyed it. And so you can make a very positive difference in your life by reducing the amount of alcohol that you're using as well, or letting it go completely. And that's one of the messages in a book as well.
Yeah, Bill mentioned my work on preventing depression. Back in the 1980s, NIMH had a document called Depression, What We Know. And in it, one of the things it said was, in general, the onset of major depressive episodes cannot be prevented. I was very upset by seeing that because there was no evidence either way. And I actually, with my colleagues, ran the first randomized controlled trial specifically to test whether the onset of depressive episodes could be prevented. And now, 40 some years later, there's a lot of evidence that we can, in fact, prevent the onset of new cases of major depression. My own work has focused more on preventing postpartum depression or depression during pregnancy. And now the U.S. Preventive Services Task Force just a few years ago came out with recommendations in JAMA, the Journal of the American Medical Association, that we should be providing preventive interventions. And they specifically listed the intervention we had developed called the Mothers and Baby Scores as something that could prevent 53% of new episodes of perinatal depression, which is amazing when you think about it, right? I mean, so going from it can't be prevented to we can probably prevent 50% of new episodes is just amazing to me. And some of those ideas are in part 4 of the book, the kinds of things that we've used, which are basically the same cognitive behavioral methods that we've learned in terms of treating depression. They can be used to manage people's mood. The idea being that with stress, we eventually develop depression and we cross a threshold into a clinical depression, and then treatment can help with that, of course. But if we could begin using those mood management methods before we cross threshold, then we could prevent the episode from occurring. And we know that once somebody has one episode of major depression, the likelihood of having another goes way up, something like to 50%. And if you have 2, it goes up to 70% and so on. So if we could prevent the first one, we might be able to prevent chronic depression throughout somebody's lives. And even if we can prevent it after the first or second, we're still, doing something. So those ideas are in part 4 of the book. And we hope they'll be useful too to people.
It's more generally a hope with our book, I think, that the information there can help people to not have trouble with alcohol in the first place, to never be harmed by it or to never develop a problem with it.
You had mentioned a little bit ago adolescence and how early those problems can start. And I think in the book you also mentioned older adults. Can you speak to the challenges that alcohol use or alcohol overuse can have on older adults?
Well, the rate of alcohol problems goes way down with older adults, of course, in part because people who use a lot of alcohol don't live that long. But I live in a retirement community. And also, when you retire, you may be losing the main source of meaning that you had in life. And also, if you're changing the place you live, so much is shifting around you. And if you're isolated, which is a real risk factor for depression and for alcohol problems. If you also get isolated, it's just too easy to drink and watch television. And so there are some things in the normal aging process that can put you at higher risk of then developing habits of drinking too much and some of the consequences of it. It's not nearly so common as it is with adolescents. In the teen years and early 20s, those are the peak years of having difficulty with alcohol and indeed of dying from alcohol-related causes. So both of those, the kind of the young years and the older years, alcohol problems can occur anywhere in the lifespan. I guess in our treatment programs, it was people in their 40s were about the average age coming in. Having developed problems already.
I wonder about that too, if you could say more about that, because I think I see that a lot too, that maybe it had been steadily increasing over time, but then in the 30s and 40s, it feels like the rubber hits the road for some reason.
Yeah, it is. It sneaks up on you. It is a gradual thing. And so even if people don't drink like they did in high school or college, nonetheless, they develop a habit of just having alcohol there. And over time, the effects build up in the brain. And so it can take a while to catch up with you, or it can affect employment, you lose a job, or you lose a marriage, a relationship. and problems like that begin to hit in 30s and 40s. And that's the kind of the average time when people come into a specialist treatment program. But we're interested in helping people way before that time. Mm-hmm. The Drinker's Checkup was an example of that, to try to help people take a look at their alcohol use and decide if they want to make changes before they're really in serious trouble with it.
Mm-hmm. Ricardo, you mentioned part 4 of the book, and it sounds like there are some great CBT ways of thinking about thoughts and evaluating. Are there other substitutes or in part 4?
We also have a section on mindfulness. So the cognitive behavioral approaches to depression focus on recognizing what thoughts are harmful and helpful in terms of mood. So they're very active. And mindfulness is another approach, right, in which you're not actually trying to change anything. You're trying to increase awareness and equanimity, right? Trying to be aware of your thoughts, feelings, your behaviors as well, but not necessarily reacting to them or judging them at all, just becoming aware of them. So the whole idea of drinking, for example, is to consider your drinking, but not necessarily having an emotional reaction to whether you should drink or not, but just being aware that you're drinking. How much are you drinking? What is the impact of drinking on you, and so on. Just being aware of it without necessarily reacting to it. We talk about things like the stream of consciousness, for example. We have a stream of consciousness throughout our days, and how that stream of consciousness can lead to feeling negative feelings, depression, anxiety, and so on, and how you can actually redirect that stream of consciousness by recognizing which thoughts you're having and what the impact of those thoughts are. One of the things that Bill has written a lot about is the consequences of thoughts. It's not whether the thoughts are necessarily accurate or not, but what are the consequences of thoughts. And so we talk about those things. We talk about how thoughts have a tremendous impact on our body. The example that we mentioned, for example, is nightmares, right? Nightmares can produce tremendous emotional impact on them. You can wake up sweating from fear and so on. Nothing is happening. You're just having a thought that your brain has created. And we talk about how you can also have daymares, like nightmares, right? In which while you're awake, you begin thinking, or your brain comes up with ideas that really scare you or make you very depressed. And how you can change those thoughts in ways that will be less harmful to you. We talk about how harmful thoughts are, like the kinds of things. We talk about thoughts as sentences you tell yourself. And harmful thoughts are the kinds of sentences that somebody who doesn't like you would tell you, someone who wants to hurt you would tell you, like you're a loser, you'll never amount to anything, etc. Right? And helpful thoughts are sentences you tell yourself as you would talk to somebody you care about. Supportive kinds of things that you would say. And again, becoming aware of how these sentences you tell yourself and how the things you do each day have an impact. We talk about how at every moment we have 3 choices. We can think or do something that will improve our mood and our health, leave it as is, or make it worse. And we're making these choices every moment throughout our day. And the more choices we make that are helpful, the better our mood and our health is at the end of the day. And if we make choices that are not helpful, harmful, the worse our mood and health will be. So we talk about all these ideas that I've been working on these things for 50 years now. My dissertation was actually done with Pete Lewinson, who was one of the pioneers in behavioral activation. And we talked about self-control methods for depression. And I'm still using those things that I worked on with my dissertation even now. So, and I sent you a link to some of our manuals, which are available at no charge to anybody who wants to use them on preventing and treating depression. And they're available in English and Spanish, almost all of them.
Yeah.
And some of them are available in Chinese, Japanese, Korean, Greek, Persian. It's just amazing. Yeah. But they're all available for free in that website that I sent you. So
yeah, I'll link them all in my show notes. I couldn't believe how much information is there, as even you have manuals for group facilitators and for participants.
Yes.
All smoking cessation, you have so much there. I mean, it's like I said, I've gotten more information in the week leading up to this chat than ever before from the both of you. It's just so neat to see 50 years of research from two people come together.
You know, when I immigrated from Peru when I was 10, and before I did, my mother sat me down and said to me, your father finished primary school, I finished high school, but we want our kids to go to university, but we don't have the money to send you. So your father has decided to immigrate to the U.S. where there are a lot of educational opportunities. And when you finish your education, we want you to share what you've learned with people here. So that's the mission. I came to the Mission District in San Francisco. And this still is what drives me. You know, I'm trying to share what I've learned. In addition to the stuff I've done in person, you know, with prevention and treatment interventions, I've also done work on internet interventions, worldwide interventions to help people stop smoking using, again, mood management approaches and so on. And so I've been able to reach thousands of people in Peru and throughout the world. So I'm doing what my mom suggested I do.
Yeah, you made good on your commitment.
Yes, sharing what I've learned with as many people as I can.
We were both affected by an article in our graduate training called Giving Psychology Away.
Yes.
Actually, psychology for the promotion of human welfare. But the central idea was we have a responsibility to share with the public what we have learned that helps people. And that's kind of driven both of us in the kinds of research that we do.
And we're very aware that these methods are not going to help everybody, but they help a lot of people.
Yeah.
Right. And many are people who don't have access to professional counseling. You know?
Right.
And so that's why we try to make it available in books and other forms.
I'm passionate about that too, with the availability to access all kinds of information. It feels really important to me that people can access evidence-based and accurate information along with any other information they might be receiving. So I think it's neat. I can feel that goal from both of you. How did you come together on that first book in 1976?
We shared a Quonset hut. We were both in graduate school, and the University of Oregon had these little rickety buildings that I think were left over from the World War. And we were assigned to one of those as an office. And so we found ourselves in the same space and became friends through school and through spending time together as well. And just got interested in this topic and decided to write a book about it. And that's where it started. So it was my very first book.
Bill and I were in graduate school together. He was a year ahead of me. And when he began his dissertation, he decided to prepare this book and invited me to join him. And again, we've been working together for 50 years. And of course, Bill became famous for his work on motivational interviewing. I mean, that's probably what he's best known for all over the world. It's just amazing. It's being used not only in psychology, but in medicine, in other areas. It's just amazing how far it has gotten. So anyway, I was very fortunate that I shared that little Quonset hut office with him way back then. And we're still friends. We get together about every month to chat about life.
Oh, that's great. I was really moved to see the decades of collaboration just as you've updated this book. It seems like such a service to come back, review the literature, and observe that things change in the process of writing these books.
Indeed.
We want our work to be current.
Yeah.
As current as we can, yes. And things have changed, and so we've changed with those things, yes.
Yeah. Bill, can you talk a little bit about motivational interviewing? And I don't think you mention it explicitly in this book, but I can feel elements that guide your work, of course.
Sure. Yeah. Well, again, I developed that in the early 1980s. And at the time, the addiction field, the addiction treatment field, was very moralistic and authoritarian. And a therapist might literally say to a person coming in with alcohol problems, sit down, shut up. You don't know anything. I'm going to tell you what's wrong with you and what you have to do. And it was based on the mistaken idea that alcohol and drug problems come with a personality disorder. And the personality disorder involves extreme defenses and denial and so forth. And that was thoroughly believed in professional aspects of this field. It turns out that was a result of the way in which we were treating people. And if you treat people with disrespect, as if they don't know anything and you're the expert, guess what? They get defensive. You know? And so there never was a personality pattern like that, unique to people with alcohol problems. And motivational interviewing was almost the exact opposite of that approach. Lots of listening to people, interested in their own perspectives, trying to find their own motivations for change. So rather than trying to install something that's missing, rather to find in people that which they already have, that helps them move in the right direction. And a simple idea from it is that ambivalence about change is normal. That whenever we're facing the possibility of making a change, of course, some of us says, you know, I can see that. And some of us says, no, I don't think so. I like the way I'm living my life. If you counsel in a way that takes all the good lines, you have a problem, here's what you have to do. The normal response is, no, I don't. You know, I don't really have a problem. It's not that much of it. I don't really want to do that. And it's literally caused by the way the counselor is working with the person. Right? Motivational interviewing takes it the other way around. And I want to hear the person's own perspective, their own reasons for change, and to have them literally talk themselves into changing rather than me trying to talk them into changing. And that was really different from the way addiction was being handled at the time. I think the treatment field has moved a lot in that direction now.
Yes.
And it turns out the reason this crosses professions and nations so much is that ambivalence is just us. That's human nature, you know. And in healthcare, you know, if you're diagnosed with diabetes, as I was 20 years ago, I was sent to a diabetes educator who said, sit down, I'm going to tell you what you have and what you need to do, and gave me about 12 behaviors I needed to change. And I did change them, but I also sat there thinking, I may know a better way to do this. And in medicine, just telling people what they have to do doesn't work particularly well. But motivational interviewing, inviting people to talk about their own motivations for change, actually does. So it's being used in dentistry, just to get people to floss their teeth and brush their teeth. Just even simple stuff like that.
No. Yeah, I mean, I hear talks about that in the medical school here, you know, both at UC San Francisco and at Stanford. Presentations on using motivational interviewing with people with schizophrenia recently, for example. It's just amazing how much that approach to providing healthcare has just permeated all sorts of fields, not just in the US, but internationally. It's just amazing. Yeah.
Yeah. I saw on an intake at a doctor's office earlier in the year, I was to check as a patient, whether I was contemplative or pre-contemplative in my commitment to a new doctor. So it's neat to see, like you're saying, because it is woven throughout just how we think about things now for a lot of people who've been trained.
I think Bill and I, although we're primarily focused on cognitive behavioral methods, also we're very much influenced by Rogerian interviewing methods. Our mentors in grad school in the first year of clinical training taught us how to use Rogerian interviewing to begin to develop a bonding with our clients that then helped to move along into the more of the cognitive behavioral stuff. And I think that's been really important in both of our development. When I came to work at San Francisco General Hospital, one of the things I found is that a lot of the people who were coming were being treated in a very disrespectful way by everybody. I mean, you know, most of them were not white. All of them were poor, usually sick. Many didn't speak English and so on. And so they were treated really badly by people around them. And just giving them a sense of respect was, you know, the most important thing you could do before you began any kind of treatment or prevention intervention. So that's really being important. Yeah.
Bergen was a very like Uber behavioral program. So when you graduated from there, you were going to be a behavior therapist and use these techniques. But the faculty had the wisdom to say, but before you start learning and doing behavior therapy, we want you to spend a year learning how to listen. Yes. And learning how to talk to clients. Yes. And hired a person who was an academic grandchild of Carl Rogers to teach us that. And it became the way I did behavior therapy my whole career. And behavior therapy works just a whole lot better. Yes. When you respect people and you listen to them and you notice what they do well and affirm that, and you're a real genuine person, not a distant masked expert of some sort, you know. It just works better at doing it in that way. And I'm so grateful that we had a year of that before we laid hands on techniques.
Yeah, I see that. I think that is so important when I work with an intern or an associate level person. That is the most important thing. And some of these folks coming through now were at home for high school during COVID. You know, some of the students getting into grad school now. And so some of those just sitting with a person elements seem to be so integral. It's really neat to hear how that was woven for an entire year. So yes. For the clinicians listening, what are some of the things that they could take away or apply through that lens, like just working with a client?
I wrote a book, published it a few years ago, called Effective Psychotherapists. And Dr. Moyers and I just got interested in why is it that therapists allegedly doing the same treatment get such different outcomes, that even in the same clinic and the same agency, everybody using the same treatment manual even. One of the big predictors of how clients are going to do is the therapist who treated them. What is it about that? And so we went back through 70 years of psychotherapy research to ask that question. What is it about therapists whose clients get better? And how are they different from therapists whose clients don't do so well or even get worse? You know? And we came up with 8 characteristics of those therapists, which are not personality characteristics, but are skills, are ways of working with people. And number one on the list, because it has the biggest effect, is empathic listening. If you listen well to your clients, they're more likely to get better. Across theories, whatever manual you're using, affirmation of noticing what your clients are doing well and what's good about them, what's strong about them, and being sure to comment on and affirm those things. Acceptance of people as they are. There's a lovely paradox, you know? And it's Carl Rogers. He said, if I feel unacceptable, I'm ashamed, I'm a bad person, I'm not okay, it's very hard to change. And when I experience acceptance as I am, it becomes possible to change. You know? Why are we wired that way? I don't know, but it seems to really be true. You know? Just pragmatically, just having very clear goals for therapy, that you and the client both know where you're trying to go and you agree about that. That's an important piece as well. Yes, giving information and advice also, but it's how you do it. You can do it in a way that the walls of defense go up and the person can't hear it. You can do it in a way that is respectful of the person and they can listen to you and do what they need to do. So it's the how of doing these other techniques, whether they're medical interventions, or cognitive behavioral psychological interventions or whatever they are. Besides the what of what you're doing, there's the how of what you're doing it. And it accounts in psychology for at least as much outcome as the particular techniques that are being used.
Mm.
You know, Bill's mentioning the thing of accepting somebody the way they are. We have a quote in the book from Suzuki that says, "You are perfect the way you are, and you could use a little improvement."
That's the balance about ourselves too.
Yeah. Yeah, the dialect, they'd say acceptance and change.
Yes.
They're not inconsistent.
Yes.
Yeah.
That people have value, that they're valuable, they're worthwhile, just as they are.
Yes.
But there are things that they're happening in their lives that are causing them problems, and that those things can be changed, you know?
Yeah.
Again, the idea of self-efficacy, we can actually make those changes, which I call the healthy management of reality. We can shape our lives. We can shape ourselves in ways that we choose to do, that are not forced upon us, or that somebody doesn't tell us, you're a bad person, you got to do this. But something that we can choose by being aware of what we're doing and being aware of where we want to go.
Yeah. I don't think I could manufacture a better closing thought if I tried. That being said, is there anything else that feels important to capture from our conversation today? I know people are going to be curious to check out the book because it could be helpful for the clinicians listening to help guide clients, and also for the clinicians listening who may need this support themselves.
We did find in my dissertation that when we gave people this book at the end of treatment, we randomly decided whether people would get the book or not. Those who were given the book continued to decrease their drinking, and those who didn't receive the book just stayed where they were at the end of treatment. So they were able to continue making changes over time with a little bit of guidance. And that was what got us started thinking about, well, what if you just gave people the book? And it turns out they could do it too.
Yeah.
Yeah. So interesting. I did notice in one of the articles that when therapy alongside the book was effective, it was because of empathy, right?
Well, yes. I mean, that's almost my other book, but yes. But we did find big differences among the therapists. And the most empathic therapist, 100% of her clients were successful in making changes. And the least empathic of the 9 therapists had a 25% success rate using the same manual.
How did you track that? How could you track those differences in empathy in that way?
We couldn't even afford video recording at the time. So we were watching through a one-way mirror. Yeah. And had 3 different supervisors, all of whom were rating the therapists on empathic listening using a scale that Carl Rogers' students had developed. And we just rank ordered the therapists and with high level of agreement, boy, this one was absolutely the best listener. And at the other end, 2 of us rated that person as 9 and the other 8 out of 9. And so just that rank ordering had a big effect on the likelihood that clients were going to be changing, even though all the therapists were following the same manual.
Oh, how cool is that? Any closing thoughts, Ricardo? Anything else to note?
Well, just to reinforce that we hope people will be able to make their own choices. At the end of the book, we say, alcohol, like tobacco, is a dangerous drug with potential to cause serious harm and snare people in compulsive use, but it has also been around for a very long time. And many people have learned to use it without causing problems for themselves or others. We know that recent information about risks has led many people to rethink drinking. Making your own rational choice about drinking is far preferable to waiting for some major life event to occur that forces you to change. It may even prevent such an event from ever happening. We wish you all the best in choosing your own way.
All right. Thank you both so much for your time today.
Thank you, Lorain.
Sharing with us what you've been working on. Thank you for listening to the Self-Carapist Therapist. I hope today's conversation gave you insight, clarity, or a tool you can take straight into your clinical work. If you found this episode helpful, be sure to subscribe to the show on YouTube and leave a review on Apple Podcasts or Spotify. It helps other therapists find the show and keeps these conversations going. Until next time, keep learning, stay curious, and take care of yourself too.